Dear ladies and gentlemen, greetings from the Malaysian Obstetric Medicine Society. I think it's timely to review an age-old disease, a very common, a significant, but a condition which I believe we have just merely scratched the tip of the iceberg, a condition that I still, for one, find it challenging to manage, pre-eclampsia. In today's talk, I would like to highlight three things: the role of the partner with regards to pre-eclampsia disease and prevention, everyone's favorite medication, aspirin, and the new kid on the block, statins. And is it time for us to start statins with regards to pre-eclampsia prevention and with regards to pre-eclampsia treatment? So, ladies and gentlemen, I've got no conflict of interest in this talk, and that is what I would like to declare. In the next 40 minutes, I would like to highlight the new kid in the block, a biomarker which is so promising with regards to screening and diagnosis of preeclampsia is PIGF. The important role of the partner and preeclampsia pathogenesis, two villains that we must appreciate, as fleet and as endoglin, which plays a significant role in endothelial dysfunction, and two medications which are commonly used to prevent, aspirin, and one medication which is promising, statins. So, ladies and gentlemen, as mentioned earlier, I find the diagnosis, I find the management of preeclampsia challenging. I think what we now understand is merely the tip of the iceberg. But I'm glad to say that in the last decade or so, we have made significant progress on this important condition, which I hope to share with you all today. Let's relook the top 4 causes of maternal death in Malaysia. The leading cause is PPH. The second cause is medical disorders in pregnancy, especially cardiac disease. The third cause is pulmonary embolism. But ladies and gentlemen, hypertensive disorders in pregnancy is the 4th cause of maternal death in Malaysia. It has been the top 4 causes in the last 20 years. It is the 10th cause of maternal death, but if it's the top 4 cause, it means there's still lots that we need to do, especially if we are to drive the cause of maternal deaths from hypertensive disorders in pregnancy. I believe this graph will change the next time I speak to you all. The leading cause will, of course, be COVID-19, but I believe if we don't do anything significantly now, hypertensive disorders will be here to stay in the next decade. So it is important that we relook our preventive strategies. Ladies and gentlemen, let's redefine preeclampsia. For many years, we have been engrossed with one single organ damage called the kidney, and we have been trying to quantify proteinuria. But now, ladies and gentlemen, as early as 2013, we have redefined preeclampsia. It is gestational hypertension with one organ damage. It can be the brain with regards to a hemorrhage. It can be the eye with regards to a hemorrhage. It can be the heart with regards to left ventricular failure. It can be the lungs with regards to APO. It can be the placenta with regards to IUGR, or it can be the kidney with regards to proteinuria. So any patient with a combination of gestational hypertension with one organ damage, which is multi-system, it is known and defined as preeclampsia. We should stop just merely looking at the protein. And the hypothesis for preeclampsia for many years remained strong, although poorly understood. The hypothesis now, ladies and gentlemen, is a suboptimal secondary trophoblastic invasion that happens at 20 weeks. But some people postulate that the secondary trophoblastic invasion is abnormal, and this is contributed by the abnormal primary invasion. So our aim and role now is to prevent an abnormal primary invasion, which takes place at 12 weeks. Hence, some people believe starting aspirin before 12 weeks does not cause miscarriage, does not cause fetal gastrocrisis, plays an important role in preventing the primary invasion, and hence earlier initiation of aspirin is far more important than later initiation. The second hypothesis, following an abnormal invasion, is a diffuse vascular endothelial dysfunction. Now, what causes this diffuse vascular endothelial dysfunction? Let's take a look at the details. Ladies and gentlemen, before the patient develops an endothelial dysfunction, there are few biomarkers which are at play. And the villains, I would say, are two: S-fleet and S-endoglyph. And these two biomarkers, known as anti-angiogenic biomarkers, are significantly elevated, causing dysfunction, later causing hypertension, UGR, and preeclampsia. The heroes, on the other hand, are vascular endothelial growth function and PLGF. So, ladies and gentlemen, pay particular attention to S-fleet, S-endoglyph, and PLGF. So let's relook the mechanism. In a normal endothelium, your TGF is intact, your vascular endothelial growth factor is intact, your S-fleet and S-endoglyph is low. However, in pre-eclampsia, there's an increase in your S-fleet, and this binds with your VGEF. There's an increase in S-endoglyph. It binds with your TGF and causes diffuse endothelial dysfunction, which later causes end organ damage and a manifestation of preeclampsia. So aspirin inhibits COX-2. It reduces prostaglandin, it reduces thromboxane A2, and hence it inhibits and prevents preeclampsia. On the other hand, ladies and gentlemen, various other postulated medications have been purely looking at the angiogenic markers. Example, statins reduce S-fleet. Esomeprazole reduces S-fleet. Metformin reduces S-fleet. And people now postulate by reducing S-fleet, you can actually reduce endothelial dysfunction and prevent preeclampsia. And that has changed how we actually understood the disease for many, many years. Now, what is the one guideline to read? I would strongly recommend you all to read the ISHRP guidelines, which is easily available online, published in 2018, talking into classification, diagnosis, and management of preeclampsia. It is a good read. Ladies and gentlemen, we have now moved away from blaming the mother for preeclampsia, because now we know it is actually a couple's disease. It's actually a disease that affects the first pregnancy. It's a disease that affects primary paternity. It's a disease that affects teenage mothers. It is a disease confined to couples who are subfertile. It is also a disease where can affect the mother if the husband is unwell. And so there's a genetic conflict hypothesis. Now let's relook on how an unhealthy father may manifest and cause preeclampsia in the mother. If the father is undernutrient, has got a nutritional deficiency, if the father is obese, if the father smokes, if the father has got a sexually transmitted disease or an infection, that can cause a significant reduction in the sperm quality. And this is known as the epigenetic theory. So an abnormal father may cause an abnormal epigenesis, causing an abnormal DNA mutation, causes an abnormal sperm function. And this affects the placenta, causing a significant degree of inflammation and oxidative stress, which later manifests as preeclampsia. So apart from asking the mother, how old are you? Are you fit and healthy? Have you mothered a child of preeclampsia before? Do you have a family history? It's also important to know father, paternal's history, the age of the father, the BMI of the father. Has he fathered a child with preeclampsia before? Because this should be taken into the equation if you are to prevent preeclampsia. So, ladies and gentlemen, to prevent preeclampsia, it's important to ask, has the father fathered a child with preeclampsia before? If yes, this mother has got a twofold increase. It's also important to know how long they have been together in that relationship. If they stay together, got married and got pregnant during a short period of time, within 6 months, the mother has not desensitized herself to the foreign antigen called sperm, the mother may have an exaggerated response, an exaggerated stress and inflammation, which may cause preeclampsia. So the recommendations for prevention of preeclampsia is to live together, stay together for a period of at least 6 months, at least 30 sexual acts before embarking on pregnancy, and that seems to be protective. You do not want the pregnancy to be too short. On the other hand, you don't want to have a long interdelivery interval because the mother who is sensitized now is desensitized, and that can also cause preeclampsia. Interestingly, for IVF pregnancies, it is also important to know whether the mother had an ovum donation or a sperm donation, because these are all significant risk factors for preeclampsia. If the husband is subfertile, nature had concluded that the husband has got possibly a genetic predisposition or a disease, and that itself can cause and exacerbate and manifest as preeclampsia. And finally, if the father has got an infection, a herpes or a CMV infection, that can also cause preeclampsia. So, ladies and gentlemen, it is not important just to ask the mother, but the father should also be as healthy as possible. I did mention about the angiogenesis and anti-angiogenic markers. I did mention about the villain being the S-fleet, which is elevated in patients with PLGF, in preeclampsia, and the PLGF being the hero, which is reduced if the patient has got preeclampsia. So, ladies and gentlemen, I'm sure you are aware of the S-fleet PLGF ratio. Now, please take this with a pinch of salt. Although this study showed that the S-fleet PLGF ratio of above 38 confirms preeclampsia, it merely does not tell you when to deliver, or it does not predict complications. The ratio of 38 is used to confirm or to negate the diagnosis. The ratio is much lower if the mother has got an underlying renal disease. The clinical benefit of this is to negate preeclampsia, but not to time or to plan the pregnancy outcomes and the mode of delivery. So, lifestyle changes to prevent, it's important to ensure that the mother is healthy, BMI below 30. She embarks on a first pregnancy below the age of 35. She's in a single partner for a period of at least 6 months. The partner has not fathered a child with preeclampsia before. The recommended interval is between 6 months to 10 years. It is not an ovum donation. It is not a sperm donor. An assisted reproductive is a risk factor, and multiple pregnancies, of course, are risk factors for preeclampsia, all of which you should try to avoid if possible. Next comes to the theory of who needs aspirin. So, ladies and gentlemen, this wonderful paper by BMJ looked into maternal risk factors and stratified their odds ratio to postulate about who needs aspirin. And I'm sure everyone is well aware of maternal risk factors for aspirin. Various society guidelines, the American Society, the NICE Society, the Canadian Society, the Australian Society, and even the ISHAP Society divide risk factors into two groups. High risk, give them aspirin straight away. Moderate risk, more than 2, start aspirin. But what are the weaknesses in these recommendations, ladies and gentlemen? The father has been excluded from the equation. IVF pregnancy has been excluded from this equation. The incidence of donor egg or donor sperm has been excluded from this equation. And more interestingly, the duration of them being together less than 6 months has been excluded from this equation. Now, what is interesting, the 2018 American guidelines seem to be slightly more stringent in their recommendations, and they have included African American. But ladies and gentlemen, preeclampsia is the fourth leading cause of maternal death. It is also a disease which is highly prevalent among Asians. Should we include Asians as a risk factor? I believe we should. Obviously, it is an American guideline, so it is not. But believe me, it is predominantly prevalent among Asians. Now, interestingly, the Americans are stricter. The BMI cutoff now is 30, no longer 35. The age is 35, no longer 40. They've also included previous adverse outcomes. But once again, IVF is not there. Donor oocytes or donor sperm is not there. So ladies and gentlemen, we can conclude from this discussion that if you go based on the current recommendations of maternal risk factors alone, it is not holistic, it is not conclusive. You need something better than risk factors. So that brings to the recommendation by the Fetal Medicine Foundation, who now recommends the triple test of preeclampsia. We have evolved from doing the triple test for Down syndrome, but now the recommendations is to do the triple test for preeclampsia. So based on these publications, if you go based on risk factors alone, you're only correct 44% of the time. And this is what we are currently doing in most of our clinical practice. You are only correct 44% of the time. It is not enough to prevent preeclampsia. If you add risk factors, if you add a biomarker called PLGF, you're going to increase it by 20% to 60% sensitivity. And that is known as the first test. Now, if you add the second test, if you add a uterine artery Doppler, you can increase the sensitivity to 66%. But if you do the triple test, which is apart from risk factors, do a uterine artery Doppler, do a mean arterial blood pressure, and add two biomarkers, PLGF and PAP-A, you can get a sensitivity of 74%. Look at the difference from 44% from risk factors alone to 74% prediction of preeclampsia with a false positive rate of 10%. And that would truly be significant, ladies and gentlemen, unless you have a policy where you give all pregnant mothers aspirin, which is technically not feasible, and you are over-medicalizing your patients. But what biomarker should you use, ladies and gentlemen? Which is better? And this wonderful paper compares two biomarkers. Should you use plasma protein A, known as PAP-A, which is cheap and easily available? Or should you use the new kid in the block, PLGF? Now, based on this paper, it showed that PLGF was far more sensitive as compared to PAP-A in screening for preeclampsia. And if you were to use one biomarker, use PLGF. Having said that, ladies and gentlemen, I appreciated how bad history is, how non-holistic history is, the importance of the triple test. Let's come to prevention. So how much of aspirin should you give? Should you give 100 milligrams or should you give 150 milligrams? Well, the Aspirin trial, I think, was a very important paper just published almost 4 years ago. It randomized patients into two groups. Patients who have got risk factors for preeclampsia were given 150 milligrams of aspirin as compared to placebo. And they showed that in the cohort who were given 150 milligrams of aspirin, there was a 93% reduction of preterm preeclampsia, which is defined as preeclampsia before 34 weeks. So this paper changed practice. It was important on two perspectives. It showed that 150 milligrams was safe It did not cause miscarriage, did not cause gastroparesis, and 150 milligrams caused a 93% reduction in preterm preeclampsia. So, ladies and gentlemen, I, for one, routinely give most of my patients 150 milligrams of aspirin. Having said that, there was one American paper who gave based on the patient's weight. And I think that is also an important principle to go by with. So, the patient is extremely thin. The patient weighs 40-45 kilograms. To give the patient 150 milligrams of aspirin may be a little bit too much. So I give such patients 100 milligrams of aspirin. But for most other patients with a normal weight of obese, I give them 150 milligrams of aspirin. Now, when should you start aspirin? So remember the hypothesis of preventing an abnormal primary invasion. So aspirin can be given when you have confirmed fetal heart activity, although the NICE guideline recommends at 12 weeks. When should you stop aspirin? The NICE guideline recommends stopping at 36 weeks because it postulates that term preeclampsia can easily be managed. By my understanding, ladies and gentlemen, it's important to ensure that the mother remains well. There's no adverse pregnancy outcomes throughout the pregnancy. And we also know that aspirin does not cause PPH, neither does it cause spinal hematomas. Hence, there's no need to stop aspirin prematurely at 36 weeks. And I continue aspirin from fetal heart activity until the patient delivers, and I give them 150 milligrams of aspirin. So with that, ladies and gentlemen, should we ban 75 milligrams of aspirin? I think we should, for a few reasons. The minimum dosage of aspirin to be efficacious is 81 milligrams based on the largest cohort from US. Having appreciated that, the Aspirin trial showed 150 milligrams. Secondly, ladies and gentlemen, when you break aspirin, if you keep it beyond 4 hours, it becomes oxidized and it does not work. So if a patient was to take 75 milligrams of aspirin, the patient will have to break a new pill and discard 3/4 of them. That is a complete wastage of medications. Aspirin should be best taken at night because that causes a significant reduction in the blood pressure in the morning. Aspirin is best taken at 150 milligrams, and you should discard the remainder of the aspirin once broken. And that is the science related to aspirin. Now, interestingly, this PIGF paper, just published in 2016, also showed that at 75 milligrams of aspirin, we have got a resistance of 30%. So, ladies and gentlemen, please stop using 75 milligrams of aspirin. The minimum dose should be 81 milligrams. For small minority of patients, you can use 100 milligrams. But for most patients, give them at night 150 milligrams, discard the remainder, break a new pill every day. And I think we should stop using 75 milligrams of aspirin in Malaysia. Now, what if the patient develops aspirin allergy? Can you substitute aspirin with another anticoagulation? The answer is no. Ladies and gentlemen, aspirin at low doses inhibits cyclooxygenase enzyme COX-2, and that causes a reduction in prostaglandin and thromboxane A2. And that is the mechanism that we are interested in. This cannot be mimicked or replicated by other anticoagulation. It is not the platelet aggregation that we are interested in. It is not the thrombosis, but it's the inhibition of COX-1. So if the patient has got an aspirin allergy, I normally take a far detailed history and ask if they have got an additional NSAIDs allergy. Sometimes it is not the allergic to aspirin, but it is the components in that medication. So sometimes I switch them from aspirin to cardioprin, or from cardioprin to aspirin, or use a different formulation or a different medication with the same content of aspirin. On the other hand, the patient was known to have aspirin allergy. You can confirm the allergy by sending them to an allergy clinic. And one other option is to desensitize them by giving them chronic low dose of aspirin so that they are desensitized. However, if you found them for the first time in pregnancy with an aspirin allergy, my own clinical practice is to admit them, challenge them with a very low dose of 50 milligrams of aspirin. I will observe them closely for reactions, and I will slowly titrate the aspirin dose over 3 to 4 days to a maximum dose that they can tolerate without side effects before maintaining that dose. So your options are convert to a different medication, use a low dose, titrate to a therapeutic level that they can tolerate. This is how I manage patients who have got aspirin allergy. Now, ladies and gentlemen, as mentioned earlier, the beauty of aspirin is the inhibition of COX-1. Hence, you can't use another substitute or another alternative. The studies are clear that there's no role for low molecular weight heparin in prevention of preeclampsia. However, in certain patients who have had preeclampsia with aspirin failure, which is placental mediated, I tend to start a second agent, a combination of low molecular weight heparin. So if the patient has been on 150 milligrams of aspirin, the patient has been discarding the medications, has been taking it correctly at night, has got a placental cause for preeclampsia, which means the patient did not have an SLE, does not have a thyroid disease, does not have a diabetes, does not have an abnormal fetus. It is purely a placental cause and had an aspirin failure. I would add aspirin plus low molecular weight heparin as a preventive mechanism. And this wonderful ACOG paper, a systematic review, also concludes that aspirin plus combination with low molecular weight heparin prevents placental-mediated preeclampsia. So the moral of the story, it has to be placental-mediated, not a maternal or a fetal cause. It has to be in patients as a second line, not as a first line. Having understood that, now it's time to appreciate the three birds which are always being mentioned with regards to studies and preeclampsia. So the three birds are the Parrot trial, the Phoenix trial, and of course the Peacock trial. So you must know the Parrot trial. The Parrot trial was a trial looking into PLGF, my favorite biomarker, into women who have got preeclampsia and looked into, is there a role to do PLGF? Now, yes, the Parrot trial was a positive study. It showed by uptaking PLGF, there's a significant reduction in maternal adverse outcomes. It does not tell you when to deliver. It does not tell you how to deliver, but just by checking PLGF, you can diagnose preeclampsia faster, and there's a reduction in adverse outcomes. Now, that is currently leading to the Parrot 2 trial. The Parrot 2 trial is still being evaluated. The results are widely anticipated. The Parrot 2 trial is looking into the role of repeat PLGF and seeing whether that is beneficial with regards to maternal or fetal outcomes. It might change the way we practice, and the results are being anticipated. So we've appreciated Parrot 1, we've appreciated Parrot 2, the Phoenix trial. The Phoenix trial looked into planned preterm delivery of preeclampsia after 34 weeks as compared to expectant management until 37 weeks. The Phoenix trial showed that planned early delivery was associated with less adverse maternal outcomes and no increase in fetal outcomes as compared to late preterm delivery. So the Phoenix trial showed after 34 weeks, it is safe to deliver the mother, and there's less benefit in waiting until 37 weeks. Then came the Peacock trial. So the Peacock trial was a follow-up trial from the Phoenix trial. The Peacock looked into the role of prognostic biomarkers such as S-fleet and PLGF. Unfortunately, it showed that by doing these biomarkers, there were no role in guiding decisions with regards to timing of delivery. So just like what I've mentioned earlier, Asfleet and PIGF is to exclude to diagnose preeclampsia, but you cannot use it to time delivery. And this result was wonderfully concluded in the Peacock study. So, ladies and gentlemen, now let's move away from aspirin and look into various other medications which may prevent preeclampsia. For many years, people postulated about the incidence of hyperhomocystinemia. I'd like to state one fact that hyperhomocystinemia is never part of hemophilia. Please do not routinely check or screen because a significant amount of our population have got hyperhomocystinemia. It does not have any clinical implications. There's no need to screen. There's no clinical implications of miscarriage, preterm delivery, IUGR, or pre-eclampsia. You don't actually have to give these patients prolonged use of folic acid. Why do I say so? It's because of the FACT trial, which was published in BMJ almost 4 years ago in 2018. So the FACT trial was a double-blinded randomized controlled trial study giving every single pregnant mother folic acid and see whether there was a reduction in preeclampsia. And obviously it showed there was no benefits of folic acid beyond 12 weeks of pregnancy with regards to preeclampsia prevention. For the take-home message, do not screen for hyperhomocystinemia. It does not cause preeclampsia. There's no role for folic acid. Calcium, my favorite substitute after aspirin. So there's a growing evidence now, especially in the last decade, with regards to the benefit of calcium. So the calcium reduction, there's a reduction in the concentration of calcium in pregnancy, mainly because there's an increase in parathyroid hormone activity and renin activity in pregnancy. We also know that the lack of intracellular calcium causes vasoconstriction. But a Cochrane review wonderfully summarizes that for countries and for population with low calcium intake, supplementing them with calcium actually reduces the incidence of preeclampsia, and the calcium supplementation should be at least 1 gram per day. So, ladies and gentlemen, it all depends on what type of calcium you take. Although there are no actually proper studies looking into calcium intake in Malaysia or among Malaysians, based on dietary recall, we can postulate that most of them actually have got low calcium intake as compared to the Mediterranean or Western diet. So if you take calcium lactate, it's got an absorption of 25%. Calcium carbonate has got an absorption of 40%. So the recommendation is to give them calcium carbonate. I tend to use BD dosing as compared to TDS dosing because BD dosing is better tolerated, especially in terms of compliance. So if you were to give the mother 1 gram BD of calcium carbonate with an absorption of 40%, you will actually get roughly between 1 to 1.5 grams as per WHO, as per Cochrane recommendations. And I think it is far better than giving the mother 500 milligrams TDS. BJOC also has got a systematic review strengthening the benefits of calcium with regards to reduction of high blood pressure and preventing preeclampsia. When should you give calcium? Can you give calcium after 20 weeks or should you give them earlier? The wonderful paper by Lancet 2019 showed that calcium after 20 weeks is just as beneficial as early calcium intake. And I routinely give them after 20 weeks. Early calcium intake may cause a little bit of gastric symptoms, may worsen your nausea and vomiting in pregnancy, and so you can supplement after 20 weeks of pregnancy. Now, vitamin D is my third favorite medication. It remains hypothesis. The role of vitamin D in preeclampsia prevention remains controversial. But interestingly, there's one study produced by a local university which showed that 83% of babies who are born in Malaysia are actually vitamin D deficient. So vitamin D aids in calcium absorption, has been postulated in preventing miscarriages, preterm delivery, preeclampsia. I agree, ladies and gentlemen, it remains controversial. But let's individualize our care. If the patient is obese, if the patient is tanned, the patient spends a significant amount of time indoors, the patient was actually during a lockdown, there's a significant amount of them who are actually vitamin D insufficient, not deficient, but insufficient. So I do not routinely check levels unless the patient had a previous bariatric surgery, or I supplement them as part of a multimodal approach to preeclampsia prevention. The recommendation is to give 800 to 1,000 international units of vitamin D per day. And apart from aspirin and calcium, I use lots of vitamin D in my own clinical practice. It is, after all, a supplement. Having appreciated that, ladies and gentlemen, people also looked into other medications. And one medication which was evaluated in the Strider trial was the Viagra. I believe from early onwards, this was a negative trial which we anticipated, because it is not the thrombosis, it is not the vasoconstriction that we're looking at, it is not the antiplatelet mechanism, but it is actually the COX-1 inhibition. So Viagra, a potent vasodilation, does not reduce preeclampsia, does not reduce IUGR, has got no role in the management of preeclampsia. Let's move on to some other newer medications. And Metformin XR, not the normal metformin, but Metformin XR has been postulated in preventing preterm preeclampsia. Ladies and gentlemen, the controversy, the challenges remains with preterm preeclampsia. Now, I for one find it challenging in managing preeclampsia between 22 to 30 weeks. I think term preeclampsias are easy. Mild preterm preeclampsias are not a challenge, but the severely preterm preeclampsias are a challenge. Now, why metformin? Remember the villain in preeclampsia, which is the asplit. So by giving metformin, it has been postulated to reduce the concentration of asplit, and has been postulated to reduce the incidence of endothelial damage and dysfunction, been postulated to reduce preeclampsia. So Metformin XR, I believe, ladies and gentlemen, has been proven to be beneficial in patients who are obese, patients who are diabetic, patients with PCOS, on preventing macrosomia. But perhaps in this cohort of patients with metabolic disease, those who are obese, those who are diabetic, those who have got PCOS, metformin does aid in preventing preeclampsia. But it's good to watch this space. Let's move on to the new kid in the block. I believe this will change the way we practice obstetrics in the next few years, Pravastatin. Now, how does Pravastatin actually prevent preeclampsia? So in other adult population, it reduces LDL, it prevents an atherosclerotic disease, and hence it prevents myocardial ischemia. But apart from that, Pravastatin, which is a very old statin, also decreases inflammation. It decreases oxidative stress, and it improves endothelial function by improving angiogenesis. And these additional minor effects of Pravastatin have been postulated to reduce asplit levels, and that has been postulated to reduce preeclampsia. So Pravastatin now has been postulated to be used to prevent preeclampsia and also to treat preeclampsia based on the hypothesis which I have postulated. Is it safe in pregnancy? Yes. This study was published a few years ago. It was a pilot trial looking into the safety of Pravastatins, and now we know it is not teratogenic, it is safe, it is not contraindicated in pregnancy. Now, what is the dosage of Pravastatin? We actually started with a dosage of 10 milligrams and we proved it is safe. Later studies showed 20 milligrams, but in patients with an abnormal Doppler, or patients that you're going to treat and patients who've already got a disease, the recommendation is 40 milligrams of Pravastatin. So ladies and gentlemen, I find this extremely interesting. Just like how metformin can be used for patients with metabolic disease, although the benefit of Pravastatin in preeclampsia prevention remains controversial, I believe The time is here in the next few years that this can be used to treat patients with dyslipidemia, patients with myocardial ischemia, or patients with metabolic diseases, because now we know Pravastatin is safe, it does not cause fetal harm. Whether Pravastatin can be used for the treatment and prevention of preeclampsia is something that we'll have to wait and watch, but might change in the next few years. The final kid in the block, esomeprazole or Nexium. So once again, esomeprazole has been postulated to reduce the concentration of aspirate, and that causes reduction in endothelial dysfunction. There are two trials which is currently evaluating the role of Nexium. The trials are ESOP trial and Espresso trial. There's one study that shows that a dosage of 40 milligrams of esomeprazole is insufficient, but it's good to watch this space, as this might also change the way we manage preeclampsia. Interestingly, we also know that medications in combinations work far better as compared to medications in isolation. So this trial also showed by combining two medications, esomeprazole and metformin, significantly reduces your aspirate level and may also be beneficial as compared to medicines in isolation. So ladies and gentlemen, prevention of preeclampsia is fast evolving. The way we manage is rapidly changing. We're looking at medications beyond aspirin. I think it's going to change on how we prevent, because I believe there's a significant need to prevent, identify, and manage them better. L-arginine. This wonderful BMJ paper was a randomized controlled trial study looking into the benefits of L-arginine, and they also showed that it significantly reduces the incidence of IUGR and preeclampsia, and this can be given for patients with regards to prevention of preeclampsia. Antithrombin 3 was actually evaluated in the PRESERVE trial, and just like low molecular weight heparin, this trial showed no benefits of giving antithrombin 3, because we now know it is not placental thrombosis, but it is mainly of placental endothelial dysfunction, which is the pathogenesis. Low molecular weight heparin in isolation, as mentioned earlier, does not prevent preeclampsia, and we should stop abusing low molecular weight heparin with regards to prevention of miscarriage or prevention of preeclampsia, or if the patient has got a protein S or a protein C or a hyperhomocystinemia. Low molecular weight heparin can be given if the patient has got a previous aspirin failure, or the patient is confirmed to have an antiphospholipid syndrome. And those are the two clinical benefits of low molecular weight heparin. So with that, ladies and gentlemen, I'm going to quickly touch on few other essential bits about preeclampsia. It's important to counsel, it's important to follow up all patients who are born with preterm preeclampsia, because the current study, especially this wonderful paper in PIGF, which was just published almost a year ago, showed that mothers who are born with preterm preeclampsia has got a higher incidence of developing metabolic disease, hypertension, stroke, and also heart failure. It is a common practice that we take good care of them during pregnancy. We discharge them after 6 weeks, only to see them again in the next pregnancy. And the role of the obstetrician does not stop merely after giving contraception. All mothers who are born with preterm preeclampsia should have a long-term plan and follow up. They should ideally follow up a family medicine specialist or a physician. They should have close monitoring of blood pressure, renal diseases. We should talk about preventing metabolic diseases. Similarly, babies who are born IUGR with preterm preeclampsia should also need long-term follow-up. I think that is essential. That makes a plan holistic, because inter-pregnancy care, caring for pregnant mothers in between pregnancies, it may not be an obstetrician's responsibility, but it is our responsibility to ensure that women remain healthy in all aspects of their lives. What is not recommended for preterm, for preeclampsia prevention? Bed rest is not recommended. Salt restriction is not recommended. It's not to do with salt, it's got to do with placental endothelial dysfunction. Vitamin C and vitamin E, palm oil are not recommended. Nitric oxide or marine oils or polyunsaturated fatty acids are not recommended. Please do not give diuretics, especially postpartum or to prevent preeclampsia. It does not help in the mechanism of preeclampsia, and progesterones obviously do not help or prevent preeclampsia. I also like to highlight one important biomarker which has been used extensively in these parts of the world called uric acid. So ladies and gentlemen, if the patient has got preeclampsia, there will be increase in trophoblastic proliferation. And this trophoblastic proliferation are later broken down into proteins that is further broken down into uric acids, and hence uric has been postulated to prognosticate patients with preeclampsia. That has been used as a marker. But ladies and gentlemen, let's evolve. Uric acid is an insensitive test. It increases as the maternal gestation increases. It is higher among patients who are obese. It is higher among patients who are elderly. It is higher among patients with high blood pressure. It is higher among patients with renal diseases. So I believe we should stop making clinical decisions based on uric acid. The best way to assess placental function is by checking biomarkers, especially S-fleet and PLGF, or by doing Doppler studies. And we should stop making clinical decisions based on uric acid alone. It does not predict adverse maternal or fetal outcomes. You're going to intervene more without any maternal or fetal benefits. So to summarize my talk, ladies and gentlemen, to prevent preeclampsia, we should look into reducing endothelial dysfunction. The mother has to be below 35 years of age. The mother has to be as healthy as possible. The mother has to be below BMI of 30. She should have an underlying disease treated, diseases like SLE, diseases like diabetes, diseases like hypertension. And if she's got a disease, please ensure she's as stable as possible. Example, if she's got a thyroid disease, do not change medications during pregnancy. If she's got epilepsy, do not change medications. Ensure the mother is as healthy and as stable as possible, especially in the first trimester. It's not just the mother. Ask about paternal history, the age of the father, the well-being of the father. Does he have an infection? Has he fathered a child before? What medications he's taking? What is his BMI? Important. Ensure that the baby is normal, because an abnormal baby may present with an abnormal placenta, and that can predispose to preeclampsia, which is secondary. Because now we believe preeclampsia is not a disease by itself, it's a spectrum secondary to an underlying cause. Aspirin inhibits COX-1. The aim is to reduce prostaglandin and to reduce thromboxane A1. Aspirin works wonderfully. There's no substitute to aspirin. Various other newer kits in the block, statins, esomeprazole, metformin, reduces S-fleet, the villain in preeclampsia, and we postulate that reduces endothelial dysfunction and prevents preeclampsia week before the patient presents with high blood pressure. It's important to know the birds. The Parrot study showed PLGF has a role in reducing complications. The Parrot 2 trial is looking into the role of repeating PLGF, a trial of which we are anticipating. The Phoenix trial showed a planned early delivery between 34 to 37 is far better than 37. The Hypertensive, of course, showed 37 is the best time as compared to 38. And the Peacock trial showed there's limited role of biomarkers in determining the timing of delivery. But I believe we are almost there with regards to the equation. There'll come a point of time where we'll better understand the biomarkers. So to summarize, ladies and gentlemen, pre-eclampsia remains a disease which is a challenging disease to all obstetricians. And I think we should look beyond the placenta, look at the mother, look at the fetus, look at the husband. It's important to get the aspirin right. 150 milligrams on night has to be discarded. We should stop using 75 milligrams. Biomarkers is the way forward. Uric acid has got no clinical benefits in preeclampsia management. Prevention is the key. Statin is promising. If you're interested to know more, please watch this video. So ladies and gentlemen, registration is now open. There's only 150 on-site seats. If you'd like to master pre-eclampsia, you'd like to master medical diseases in pregnancy, I will strongly recommend you all to attend this course. It's going to be a conference like no other. There's going to be 100 over topics which is going to be discussed. I strongly recommend you to register today and come and join us physically on site at the World Trade Center, which is happening between 20th to 22nd of May. So with that, I would like to thank you so much for the attention. If you need resources, please log on to www.obstetricmedicine.my. And thank you so much for your kind attention.